Hello, everyone, and welcome to today's webinar. I am Winnie Sibilak, and I'm the Senior Marketing Manager at Dreger, and I will be moderating today. But before we start, I would like to review a few technical insights. And first of all of the participants are in listen-only mode. You will notice that we are going to be recording this session. So I wanted to make sure that everyone is aware that in the future we will have this presentation up on our Breath Ahead website. So in order to ask questions of John, please go ahead and type your questions in your question box in your GoToWebinar panel and then press send. And we'll take time at the end of the presentation to go through as many questions as we can. So for today's program, it has been approved for 1 contact hour of continuing respiratory education by the AARC. So for those that are attending as individuals, a survey will pop up at the end of the webinar that I ask for you to go ahead and complete. Your certificate will be emailed to the email that you provided at time of registration. And it'll take about, within the next 48 hours, you'll see that in your inbox. For those that are attending as a group, I ask that the moderator for that group go ahead to your GoToWebinar panel and download from handouts both the attendance record and the evaluation form. Return both of them completed with your attendance record to my attention. And there's my email address right there on this screen. In addition, it's on each of the documents as well. So each participant that attends in the group will receive their certificate with the email that they provide on the attendance record. It is my pleasure to introduce today's speaker, John Emberger, the Director of Respiratory Care at Christiana Care. Mr. Emberger is a fellow of the AARC, a Lean Six Sigma Black Belt, as well as a certified professional in healthcare quality. John has a vast number of research publications and abstracts since early in his respiratory care career. In addition, he's lectured for numerous amount of national conferences as well as webinars for the last 20 years on critical care topics. John is an active member in the Delaware Society of Respiratory Care as well as the AARC. So let's go ahead and welcome John today to speak about the evolution of respiratory care in the NICU to reduce the use of invasive ventilation. So if you give me a moment, I'm going to go ahead and transition and have John be our presenter. Go ahead, John. I think you should have access.
Yes. Do you see my presentation?
Yep, very
Okay,
good.
great.
Thanks so much.
All right. I will spare the group my mug since there's a picture there and keep my webcam off, and we will get rolling. So we're going to talk about what's happened over time to reduce the need for invasive ventilation and what's sort of the future. Let's see here. Is my presentation still up?
It is.
Okay, great. Something changed on my second screen. So, okay, great. So our roadmap basically is we're going to take a walk through history. I think there's some interesting, some sort of funny stuff, some sort of scary stuff in the history of newborn respiratory support. We're going to sort of walk through some of the modern therapies, talk about NICU and delivery room as a PI team, and then I'll hopefully summarize it for best practices at the end here, so to give you some take-home points. So history, one of the things I always look at in NICU is it is amazing how far we've come in how short of a time, both with, if I was speaking about mechanical ventilation, which I frequently do, as well as this, which is everything but mechanical ventilation in a sense. I think there's some interesting stuff. If we look here, just to sort of get started, in rate per 1,000 live births, if you look just back in the early 1900s, nearly a tenth of infants died around birth time, and we've reduced that really tenfold down to about 1%. And this is only in 1985 range on this graph. The problem with these trend things is you have to wait a while to get the data. We're probably even much better than that now. Just walking through history, this is sort of a funny one, but sort of a scary one. This schematic, which is sort of crazy, I have to say was furnished to me by Kathleen Bonus, one of my colleagues at work. But this is an early respirator, if you will. It's from 1889. I think it's interesting. And they claim that they used this wooden box that I believe they probably used almost like a negative pressure ventilator 55 times successfully. Now, I don't know how you clean wood out between patients. And I also don't know how many times it was used unsuccessfully, but nonetheless, they were thinking about ventilation before the 1900s. Walking through just some other history in the 1930s, you have oxygen being put into bassinets. These actually look more like something you'd cook something in rather than something that you would take care of an infant in. This one's particularly interesting. The red arrow I point, you might not be able to tell on your picture, but that is a fire to heat water to heat the baby. To support the baby with heat. They're actually using an open flame in this system, which is kind of scary. But back in the 1930s, I guess you could do that. This here is just moving a little farther. 1950s, a resuscitation device. If the kid was doing poorly, they might be put in this positive pressure oxygen lock device, which my guess is it probably was like almost like a device just putting the patient in oxygen with pressure and hoping that they resolve the hypoxemia of the kid. And again, moving along. So up to the 1960s, this is really what is known as the start of newborn medicine. And actually, there's a really good reason for that. Either depending on what generation you were born in, either your parents or you may know about this, but it was fueled by the Kennedy baby. So the Kennedy baby was so of the president's was a 5.5-week premature baby delivered by C-section and at Air Force Base, and was brought quickly after they realized the baby was in trouble to a hospital. The baby was nearly 5 pounds, 2,100 grammer, 34 weeker. Nowadays, we don't even really think about that life being in jeopardy. But in this case, John Kennedy's here showing up at the hospital. This is a big deal, obviously, because he was a very popular president at the time. And the baby was sped to Boston Hospital. And a couple of days later, the Kennedy baby dies at Boston Hospital. So premature baby of the president actually fuels in the 1960s huge efforts to understand how do we take care of these kids. 1970s and 80s, some of these things I'm obviously, in the interest of time, brushing very quickly over. In the 1970s, the first neonatal ventilators, if you want to call them that, they weren't very good to put the infant on. They would ventilate the kid, very high rate of pneumothoraxes, no synchrony. In the 1980s, you started seeing the first surfactants available and used. To just take a quick look, and this may be small on your screen, especially if you're on a mobile device, but I'll tell you what it says. This is per 100,000 lives. The top here is year 1960, bottom is 1990-ish. So it's 1960 through 90. What was the number of kids that would die, cause of death, out of every 100,000? So RDS in the hundreds, in the 60s, down to about 62 per 100,000 in the 90s. low gestational age or birth weight in the 400s down to about 100, influenza and pneumonia in the 300s down to in the teens. So huge in the 1960s to 90s, huge things happening to help make more babies live. Just to give you a couple, another flavor of history, this is a 1988 textbook, standard textbook about the neonate. And this is the section on pulmonary care of the neonate. The first item is intubation. So there was nothing but intubation, basically. In fact, in their diagram of a kid who needs resuscitation, you hit intubation here on this branch, you O2 and bag mask ventilation here, and you hit intubation here. There's really not much but intubation back in the 80s for infants. Moving forward, this textbook in 2005, the section on neonatal care, you have bag mask resuscitation, you have intubation. Again, even at 2005, there's not really much to say about infants except if they're in trouble, bag them and intubate them. Moving forward in time, this is a 2003 journal perinatology article that looks at the kids that are ventilated. So this talk is really to show you that we can reduce, or how have we reduced ventilation over time for infants. This really just speaks to the fact that in the early 90s to the early 2000s, this line here is that this is the total ventilation hours per patient. We have reduced the ventilation time for the littlest babies and also for the biggest babies over time from the early 90s to 2000s. So ventilation, even back then, we were learning things and ventilating kids, less kids, and for shorter amounts of time. Now, this is my, I think my last part specifically on history, but we're talking about mechanical ventilation. Before I go, this is outside of the scope today, but I always, for people who are interested in NICUs and NICU care, always want to say that from what I've heard and just enlightening people, that many NICUs are not practicing evidence-based safest ventilation. This is out of the scope of my talk, but I like to mention it. If you are not doing volume targeted ventilation, and what I mean is not PCV, you need to be doing volume targeted ventilation with tidal volumes of 4 to 6 mLs. There's whole lectures on just this and the caveats here, but the bottom line is in a NICU, it should be volume targeted, and it should be somewhere in the range of 4 to 6 mLs. If you're not doing that in your NICU, then you're not following the best case, safest evidence-based practice for your mechanically ventilated kids. Again, out of the scope of this lecture, so we're gonna move on. We're gonna talk about some modern therapies, a little bit of the history of each of those modern therapies and where maybe some of them are going. First of all, intubation. The goal of this talk is to not intubate, and one of the reasons would be adverse events. Another reason is that once you are on a ventilator, we have learned, again, lectures about this, have learned to reduce lung injury on invasive ventilation, but we are not perfect, and the ventilator does support the kid, but the ventilator also does do lung injury to infants, no matter what ventilator you're using. So our goal is to not intubate. So this paper here looked at 162 infants, and they specifically were looking at the adverse events around intubation. So let me zoom this in here and show you. So they identified that there are elective intubations, there are urgent intubations, and there are emergent intubations. So urgent intubations, I always look at, they're one that is an elective that usually moves towards an emergent, and then we call it an urgent is the typical. But what they found is that there are non-severe and severe adverse events in all groups. Now, as you go to emergent, the non-severe and severe increase, but there are adverse events associated with intubation frequently. In fact, what they found is in about 40% of intubations in neonatal ICU, there are adverse events. Some of them are, again, non-severe, and some of them are severe, but they're very frequent. So we don't like to intubate people if we don't have to. Surfactant, let's move on to surfactant. So I don't have very many sort of either funny or outside of the topics. I'll just say this here is a little bit dated because this is from the Wonder Woman movie. I'm not a DC fan, I'm a bigger Marvel fan, but this is from the Wonder Woman movie, and it took place in around World War II, and this is Dr. Poison with her gas. And the reason I have that there is to remind you that surfactant, the history of surfactant was they were trying to learn why nerve agents used that the Nazis used in World War II were hurting and killing people. And what they found, an English, a US, and a Canadian researcher listed here, all looked at this after World War II and found out that the nerve gas was hurting the surfactant in the lungs, among other things. And they found out that they could synthesize surfactant different ways, and they had their first clinical trials in around 80. What we've found since then is that surfactant reduces mortality in pulmonary air leaks by 50%. In fact, surfactant has such a strong signal of reducing mortality that it actually, if you look at all infant mortality in the US, surfactant has reduced all infant mortality by 6% in the US. What we're going to talk about with a couple of slides with surfactant is the Ensure method and LISA methods. So I think they are coming up next. Let's see here. So there's a couple Cochrane analysis that I want to point out here. The first one is a Cochrane analysis from 2008 that is early surfactant administration with brief ventilation versus selective surfactant with continued ventilation. So what that is, breaking those two things down, is taking an infant that you think needs surfactant, giving it to them right away, and extubating them right away. And that is what's called the Ensure method. So it's intubate, surfactant, extubate. That's where we get the acronym Ensure. So Ensure is intubate them and give them very brief ventilation. In many cases, just hand ventilation for a minute or two while you're doing surfactant delivery, then extubate them. And so that was what this trial was about. It used 6 randomized controlled studies. And the next one in 2012 looked at 6 randomized studies, different ones, about 3,500 infants. And this is early versus delayed selective treatment for surfactant. When you look at the whole of these trials that have randomization and they have meta-analysis look at them, we find that early surfactant with extubation, that's Ensure, was better than selecting patients that need surfactant and leaving them on ventilation. You had less ventilation time, lower mortality, less BPD, and less air leaks, and all those things are good. So the Ensure method is something that you can definitely rely on using, and it's going to help your infants. So what is LISA? LISA is less invasive surfactant administration. Many of you may have heard of this. Many of you may be doing some of this. There's really 2 methods to LISA that I am aware of. Before I mention this study here, the 2 methods really are intubating an infant's trachea with a catheter instead of an endotracheal tube. And so you're getting the catheter in their trachea, which is tricky. You're giving them the surfactant during CPAP with a catheter to their trachea. And another method of that would be nebulizing surfactant to the baby. I'm going to have a study that I show you on that because that has had many different rounds of trials and finally a successful trial that was published in 2020. So the first would be adding a catheter to the infant's trachea. So you put a catheter in, and what did they find in this group of patients in this study? This is the intervention group, so they were not intubated. They were given a catheter in the trachea of surfactant, and then they were on CPAP. And over time, some of them needed intubated, but this is where they kind of settled out in that intervention group. The other infants who were intubated to give surfactant and then they were weaned off, over time, they come off the ventilator and this is where they settled out. So the difference here is the benefit of them, the number of kids not needing intubation, but they did get the benefit of surfactant. So there is a gradient here of maybe 10 to 15% that if you do LISA, you will not need to intubate quite as many infants and subject them to mechanical ventilation. The other benefit in the study that was noted was there was less pneumos, less BPD, less IVH, less problems with their eyeballs, ROP, and less patent ductus issues. So there were benefits to not putting these infants on the ventilators and just giving them surfactant via catheter. I will tell you, having done catheter-based LISA at our institution, or actually talking to a couple of people who have, I have not done it myself, but we've talked through the process and looked at the process to see what we can improve. It is a tricky process to intubate the trachea with a floppy catheter and to instill the surfactant in there while the patient's on CPAP. So what did this find? LISA did not increase survival without BPD, but it was associated with increased survival without major complications. And since major complications are related to lifelong disabilities of these kids, like if you hurt their eyeballs, they're going to have trouble with their sight their whole life, as an example, LISA may be promising for some extremely premature kids. Another version of LISA is to nebulize the surfactant. In this study, this was published in 2020. It's a decent sized study, 457 infants, and they had a modified pacifier in the infant's mouth that nebulized out the end of the pacifier to the baby's lungs. And what they found is that if you were in the 23 to 24 weeks, they're all intubated, obviously. But once you were up 25 weeks and above, the difference in these bars, the blue bars that are lower, these are the percent of infants that were intubated. So at every step along the way, different gestational ages, and some pretty pronounced. If you nebulize surfactant, you did not get as many kids intubated. And the overall population, this is the nebulized calfactant versus the kids who were treated just in a standard fashion, the number who were needing mechanical ventilation. So LISA, in this case, via nebulization, did reduce invasive ventilation. And you never know, you might be asked to help and assist to give surfactant while a person puts a catheter in a baby's trachea, or while we do some sort of nebulization for the kid. Or a third option, which I believe is being studied as we speak, is a modified LMA for neonates that nebulizes to where the trachea opening would be with an LMA. So CPAP, let's move on to CPAP. We've made reference to it already, but CPAP, I just have a smattering of things here. You can do whole lectures on this. I'm not going to, obviously. We've got all kinds of different interfaces, masks, prongs. You've got different systems. You have systems that are made to deliver to drivers of CPAP with special circuits and fluidic flip switches. And then you have things that look like, I'll say, professional versions of what we might have made as a homemade version years ago. This in particular, this is Draeger's Seattle PAP. This is F&P's bubble CPAP. So these are two of the common types of bubble CPAP. You can do it with a circuit on your ventilator, and you can get a driver to do CPAP with some sort of an infant driver, and you can use various interfaces. I can't go into too much depth in the scope of this lecture, but I'm going to hit on a few topics on CPAP. First of all, brief history of CPAP. George Gregory, pictured here, in the late 60s, realized that, number one, when you put babies on the ventilators, you get pneumothoraxes. As I mentioned before, the first ventilators were not nice to kids. In the late 60s, RDS mortality was about 50%. Bear in mind, there was no pulse oximetry yet, no ABGs yet, no surfactant yet, and he found a way to intubate kids and give them CPAP One method was, you can tell this archaic old vent circuit, this kid's getting CPAP. I don't know how well you can tell this, but this is almost like one of these pressurized hoods. It's plastic that's pressurized, and flow comes in one direction, goes out the other, and this is a modified version of giving this baby CPAP. He found ways to give CPAP, and the survival was then 80%. Immediately, many kids survived. What are the trends in the use of CPAP? This is an old one, but from 2000 to 2008, again, it's a region of the world. This is Australia, but what it shows is that CPAP has taken off, especially in the greater than 32-week population. It probably, after this, if you could find a graph in the less than 32 weeks, that has similarly taken off as well. Another thing about incidence, or when you'd use it, so this is looking at kids from 2007 to 2013. It's looking at 19,000 infants in Australia and New Zealand. They are 25 through 32 weeks. They're broken up this way. So these are just raw counts of the kids that are 25 through 32 weeks. The thing that is the open area of the bars is what in this study is CPAP that was successful. In other words, didn't need intubated. So in the early to mid 2000s here, we have much success in 28 through 32 weekers on CPAP. You can see the intubated kids also are lower in that population as well. So the more CPAP you use, the less intubated kids you have at any given gestational week here. So you have lots of use, even at 28, but definitely above 32 weeks in these kids. A New England Journal article sought to look at nasal CPAP versus intubation at birth, so in a delivery room. This was maybe the first big splash that made people very much look at, can we change things in the DR? I'm going to make reference at the end of the lecture to performance teams in the DR to figure out how can we make care better. This is maybe one of the things that spurred that on, because what they found is in 610 infants that were 25 to 28 weeks, so not huge kids, 25 to 28 weekers, were assigned 5 minutes after birth to either CPAP or intubation. And what they found is there's no difference in death or BPD. The CPAP benefits maybe showed lower death or O2 use at 28 days and less assisted ventilation, which is always a good thing to assist kids on invasive ventilation less. And what they said is overall starting early CPAP in these preterm infants was not detrimental and maybe a positive thing. So this is another study that looked at, it's a meta-analysis, looked at 4 randomized controlled trials at 2,700 kids, and they looked at CPAP versus invasive ventilation, again at birth. And what did they find? They found that nasal CPAP in the DR compared to intubation reduces death or BPD. And they actually calculated out to say that for every 25 times you're able to put CPAP on a kid instead of intubating, you actually get 1 extra survivor out of the hospital. So that's a pretty important thing there, that you can get 1 extra survivor out of every 25 treated, which is of a lot of interest. We like our kids to survive and leave the hospital. A little more about respiratory support. At birth, Pediatrics in 2014 came out with a policy statement. So this was based on evidence, a policy statement. Their new recommendation was you should CPAP babies immediately after birth and then use selective surfactant if needed. And what that means is CPAP them and then insure them if they seem like they really need surfactant. So put them on CPAP, and then if you do need to give them surfactant, pick the ones that need it and intubate them give the surfactant and quickly extubate them, and you're going to see benefits. So that was what the AAP came out with, saying this is the way you should be doing this immediately after birth for kids. So with CPAP, I mentioned that there's ventilator-derived CPAP, there is bubble CPAP, and there is infant, like there are drivers for CPAP that give, they're almost like ventilators that just do CPAP in a sense. This is from a paper in 2015. What I want to do is I have two quick papers that speak to bubble CPAP. What I'm going to tell you at first, in my opinion, knowing the literature, there are people who obviously very, very much like bubble for the bubble effect. I'm not opposed to it. I don't believe there's evidence yet to say that the bubble is better than, say, ventilator CPAP if you do both of them well. I do think that people have teased out. So if you were to look in the literature about bubble CPAP, what you would see within the last 5 years to current is that there are still lots of lung model experiments that are not really humans or not babies that they're looking at. And there are animal models that they're looking at. And whenever you see lung models and animal models instead of actual patients, you know that you're in the infancy of looking at that topic. And I believe we're still at the infancy of looking at bubble systems in general. And I don't believe we have evidence to say bubble is superior to others, but it certainly has some interesting aspects. So in this paper here in 2015 from de Blasi's group, this is out of Respiratory Care Journal, what they show here is this is the tidal volumes associated with the bubble for 4 different devices. Okay, so, and it's over different flows. So the idea is as you turn up the flow, you get bigger bubbles, maybe you get bigger oscillations, maybe you get bigger volumes that you're oscillating the kids with in addition to their spontaneous breaths. This shows the size of the volume. So the size, generally the size is about 0.2 mLs to about 0.5 mLs. A couple of them get close to 0.5 mLs, so a half ml tidal volume with the oscillations. This is a look at one of the particular devices. This is the movement of pressure at the airway, so at the baby's interface to the nose. This is the pressure movement. This is the pleth of their lung model. So it's saying, like, at the lung level, what do you see? You see much less movement. You see the movement at the airway, see much less movement in the lungs of the infant. Again, this is a lung model. It's not real kids. But the point is there's attenuation like we know about in high frequency ventilation. So the question is, and in fact, what they state at the end of this is the major finding of the study is that bubble CPAP provides a quantifiable oscillation that may prove to be clinically meaningful, and that each of the systems have different magnitudes of oscillation. So the key thing here is that we can measure it, but we don't, this isn't even in kids. We don't know if it's of benefit yet, according to this paper. This is a paper that was 2018. This is what I'll just read the title: Short-Term Evaluation of Respiratory Effort by Premature Infants. So this is in infants. As you'll see, it's a very small study. It's using Seattle PAP, which is as I mentioned earlier, it happens to be the Draeger product. And their standard bubble device happens to be the other probably most common one out there, which is the Fisher and Paykel product. So on 27 infants, we see that they used that it was less than 32-week gestation, and they were infants that were on bubble CPAP, and they were very stable, and they were on very low FiO2s, and it's within 3 days of birth. So you have fairly small kids that happen to be very stable on bubble CPAP with low FiO2 requirements within 3 days of birth. They put esophageal, basically not a balloon in, it's a catheter for kids like this. They put an esophageal catheter in, and they're measuring their effort over 2 hours on both the Fisher and Paykel and the Seattle PAP. What they resulted in, and I didn't want to show any of the diagrams. The diagrams are these different color squiggles. If you're into that kind of thing, you can pull this paper up. It's pretty interesting to look at, but I certainly don't want to bore an audience of a couple of hundred people with all these squiggles that you probably wouldn't see. But they found that it resulted in less effort during spontaneous breathing when you were on Seattle PAP. So the kids on Seattle PAP had less effort during spontaneous breathing. They note that the considerations are it's a small study, 27 kids. Again, very stable, not the sickest kids that you would use CPAP on typically. There was no blinding, no randomization, and again, relatively healthy newborns. So what the authors conclude are also after their conclusion of the reduction in spontaneous effort of these kids on Seattle PAP is whether the differences between these two devices prove to be associated with lower mortality and morbidity. It'll require an extra investigation. So the other thing too I want to note, and I just have as a bullet on this to remind myself to mention it, you'll notice a lot of bubble CPAP. Right now, the research is aimed at, can we support these kids with bubble CPAP as these kits are, as you saw in the pictures, they almost look homemade. They're very basic. And can we use them in lower resource environments? Can we take them to places, other countries outside of the US, namely, and have them applied so that they can really reduce the number of kids that die in lower resourced environments. And I think it's a great thing to put science into that and figure out how can we put something that's very basic that can be applied very easily to populations with low resources to see if we can really save like lots of infants' lives that would have died without those resources. So high flow nasal cannula, what's all the hot air about? So I don't have very much on high flow nasal cannula, and in fact there is not a lot of data out there yet on high flow. There are probably a few other papers I could show you certainly, but in the interest of time, I picked a couple to point out a couple points. This first one is a pediatrics one. This is a fairly decent sized study, 423 infants. They were all greater than or equal to 28 weeks, so on the bigger side. And they looked at CPAP versus nasal cannula. All right, so I'm going to very quickly tell you this graph. This graph is the percent of patients on the mode that I tell you they're on. I'll tell you what each of these lines are. And so this is from birth to time after birth. So these two sets of lines that are dashed lines, these are the infants that were either on that were either supposed to be on the CPAP or the high flow nasal cannula. So, and these are the number that required ventilation if they started on CPAP or high flow nasal cannula. The lines are almost identical, not much of a difference between those. So the number, if you were on CPAP versus high flow, the number over time that needed ventilation was about the same. And these are the lines of those kids who were started on nasal CPAP or high flow, and obviously over time they come off to something, either room air, low flow, or they need ventilated. Again, there's a little spread here, but all in all, they're fairly similar. So what you see is the number needing ventilation, the number coming off of that mode is pretty similar. If you look at the data charts, you look at adverse events, and you look at outcomes, very minimal differences between nasal CPAP and high flow. In fact, what they say is that in greater than 28-week gestational infants, high flow nasal cannula is very similar efficacy and safety to nasal CPAP, both as an initial therapy as well as post-extubation. So that's something to sock away in your mind. 28 weeks or greater, it probably does not matter too much whether it's high flow nasal cannula or CPAP if you need it to stop intubation or post-extubation, I should say. The next paper will seem to contradict that. This is a 2020 paper in Pediatrics where they looked at high flow nasal cannula infants after extubation, and they were against CPAP. So this is high flow nasal cannula against CPAP. And what you will find in this is that the high flow group for treatment failure at 7 days, treatment failure at 3 days, so 3 days and 7 days, there was a higher failure in high flow nasal cannula than nasal CPAP. So keep in mind what this is specific to is extubation. So when you extubate a patient in the 3-day window and 7-day window, there were more failures, meaning they needed to go back on the vent, and high flow nasal cannula versus nasal CPAP. Sounds bad for high flow nasal cannula, but they further dissected the data to identify what were the issues. And when you further dissect the data, I'll just say the high flow nasal, they dissected a high flow nasal cannula who failed and high flow nasal cannula patients who succeeded. And the main difference was gestational age and birth weight. So what they found, and remember the previous study, 28 weeks or greater, they found that if they were greater than 28 weeks and larger birth weight versus less than 28 weeks and lesser birth weight. So this actually confirms what the previous paper said is probably no difference, no problem if you're 28 weeks or greater. High flow nasal cannula, you probably want to be kind of cautious if they're smaller or less than 28 weeks of gestation. So let's look a little bit at NICU and the DR as a PI team. So this, like I said, in most recent years when people started seeing data that if you do some different things in a DR, you can change outcomes, and you combine that with performance improvement, Lean Six Sigma, all of these different performance improvement technologies, PDCA, permeating the hospitals more. It hit, the airline industry, it hit car industry, and I'm glad it did because I like knowing that I'm very safe in a plane, and I like knowing that cars are manufactured with higher and higher standards. Unfortunately, healthcare took a little while longer for PI and Lean Six Sigma, PDCA, all these types of things to get well rooted in the healthcare systems. But as that's happened, the DR has been a focus. I'll point out a couple of articles here just very quickly to show you that. So, 2011, this is 2013, 2017, and this one fell off, but this is about 2018, I think. These are all looking at like so this is 3 approaches to initial management of neonates, delivery room management, delivery room interventions to prevent BPD, eliminating risk of intubation in very preterm infants in the delivery room. So there's been a lot of interest here. And I picked a few because there's a lot of papers out there on this. A few, I think I've got tidbits from about 4 papers that are different than these that I pointed out here that look at delivery room management of patients and what things we can learn. And in this is 3 groups. This was a collaborative in California, lots of hospitals in NICUs in California. And really what they showed was, and I think I highlight some things here to just talk about performance improvement a little bit, using a checklist to prepare for all high-risk resuscitations. Checklists should be used in all of critical care things that you want to go well. Sometimes we hard code those checklists into your electronic documentation systems. Sometimes we hang them on devices, laminated with checklists of how we do things, but you should be using checklists in your practice, and you should improve teamwork and communication in the delivery room. So those are some of the key things. Another thing is, I'm not going to talk a lot about this, but it's really important they found to obtain pulse oximetry reading by 2 minutes of life. That's a really important thing. And early use, again, like we've talked about, early use of CPAP, avoid intubation. What they show in this particular paper, they showed that they increased the use of DR CPAP, increased CPAP patients that were not intubated, and they reduced intubation in the DR, among other things. They made their hypothermia better and some other things as well, but I'm just highlighting some of the respiratory stuff here. Another paper that talks about PI in the delivery room is this one here in 2016. So delivery room quality improvement project for best practices. What did they do in the DR? They actually made checklists, for example, for what the doctors need to think about, what the therapists need to think about, what the nurses need to think about in the DR to improve patient care. And when they carried out this performance improvement project, as I said, the pulse ox by 2 minutes skyrocketed, surfactant rate and intubation rate went down. The reason surfactant goes down is because intubation goes down. If you intubate a kid, you're more likely to give surfactant. And the third paper about this delivery room, using the delivery room as a PI project. This is, I don't know if you're familiar with Vaughan or Vermont Oxford Network. This is a large network in the country of hospitals that collaborate and share data. And they looked at 84 Vaughan hospitals, and they found out when they looked at the DR and resuscitation management, NICU teams were able to improve quality and safety by using formal tools, checklists, and they designed the DR to facilitate teamwork. They built in briefings, so pre-briefings, debriefings after the fact, using checklists and doing videotape reviews. If any of this stuff hasn't come to your DR, it's probably coming sometime soon, and you may or may not know these things are going on, but these things are improving care in the delivery room to make sure that we're doing the things that we need to do for these infants. And I believe, if I remember right, this is the last one that has to do with eliminating the risk of reintubation. This is 640 patients, 2019. It's a standardized bundle, and the thing that I want to point out here is they actually put in a timeline of how they improve things. And what you'll see is, things like doing DR CPAP, doing bubble CPAP, changing their intubation, extubation criteria, using lower FiO2 during resuscitation, non-invasive ventilation, high flow guidelines, gestational O2 guidelines for your SAT targets, LISA, so changing the way you do surfactant, nasal CPAP, increased amounts of nasal CPAP, targeting O2. So you can see these types of things and what they saw over time. Percent of infants intubated. These are the smallest infants, nearly all of them, 2010. As you approach 2017, a lot less of those kids getting intubated in the DR. The middle-sized kids, I'll call them in their study, less intubations. And the biggest kids, greater than 1,500 grams, even less of those intubated. So intubations in all groups reducing. So I think I'm actually at my summary for best practices. I think I've mentioned some of these things, and let me just underscore some of them. So I didn't get into why pulse ox by 2 minutes is important, but it is. If you're wondering and you're not sure, look it up. It's out there. It's prevalent, but better outcomes for infants and troubleshooting what's going on. Pulse ox in the DR by 2 minutes, and we're obviously a part of that. Sustained inflation, I didn't mention this. There was a trend several years back that may be still at your place. It was you do this sustained inflation just after birth. What I can tell you is at this point, there's inconclusive data. We don't know if we should do that right upon birth in sustained inflation. We do know that early CPAP and in larger infants, high flow nasal cannula to avoid intubation should be done. You should be using early CPAP and high flow nasal cannula for avoiding intubation. We're not really sure. I didn't address it in this lecture. Again, you probably could speculate on this with some of the literature that's out there, but we are really not sure yet about NIV other than CPAP. There's mixed reviews on that. Early surfactant is important, and it's probably most important and best if you only intubate as needed and ensure, which means extubate right away and let the patient be on CPAP. LISA, as we mentioned, less invasive surfactant is up and coming. Multiple methods, either via catheter in the trachea or via nebulization, which is making its rounds again, or which has a recent study as well, or something like an LMA that it can nebulize or instill the surfactant right near the trachea, probably of benefit, but very tricky. Not 100% sure about it yet, but probably a benefit, but is very tricky to do in practice now. I encourage you to improve teamwork and communication in a DR. I encourage you to checklist things that are important to make sure they're done on your infants, and instill a PI mindset. You should have performance improvement experts looking at processes in the delivery room and in the NICU to instill this idea of we can improve something. If we're not thinking about improving something, the outcomes in your NICU will never improve. And pre-briefs and debriefs, talking about what you're going to do before it. Simulations would be pre-briefs as well. Before you're actually there with a kid, practicing what is best, debriefing on what happened and how we could do better, and including the family. And I think on that, I will end it and turn it back over to Winnie.
Wow, great. Thanks, John. Appreciate that. What a great presentation. We've got a couple of questions coming in, and I'm going to leave your information up there for a few minutes, and then I'll make sure that I put the CRCE and how to go about getting your certificate up in a few moments as well. But okay, so let's get to some of the questions. First question was, what brand of CPAP do you use at Christiana, and tell us why?
So at Christiana, we've used a few different types of, I'll try and make this concise. From a bubble standpoint, we've used a couple different ones. Our current bubble that we use is the Seattle PAP. The reason we like that is that it's one of the main reasons I would say is that it's all packaged together, that you don't have to grab different pieces. I think the mechanics of it and how you set the bubble, people really like that as well. Like, so we've just found we've kind of anchored ourselves on that. Once that was available and we saw the literature, speak into the fact that it may be an advantageous bubble. Again, I think the jury's out on that, but it may be an advantageous bubble, but it's also the mechanics of the system and the ease of use. We've really kind of settled that as our bubble. We do use ventilator CPAP at our institution. Since we use Draeger ventilators, we also use the Draeger interfaces. We use the masks as well as the Draeger prongs for that. Yeah, we don't use any infant, like any drivers outside of that. So we use ventilator and bubble CPAP. And I can tell you our tendency, whether this is right or wrong, our tendency is DR CPAP is bubble CPAP. They come back on bubble and we maintain them on bubble. We are likely, when we extubate a patient, to use ventilator CPAP more so, but we are starting to use bubble more in those kids as well. But that's our tendencies right now.
Okay. Next question. Let's see. In the Vaughan study, did BPD incident rates also decrease with all of the interventions? More non-invasive or less invasive, lower FiO2 use?
So not having that in front of me and not being able to pull the study up just, right here in the interest of time, my guess is yes, because all of those things do reduce BPD. I can't remember whether it was statistically significant or not. And as that person kind of asked a loaded question, yeah, all of those things are the types of things that do reduce BPD. So my guess is that bears itself out in that data as well.
Right. Right. We're getting several great presentations. Thanks so much for all the literature review. It's packed with very valuable data. Love hearing about the history. I think it's important to reference the point as to why some aren't using best practice. So Do you have a comment, maybe just because of the way they've always done what they've always done?
So,
Um,
so I mean, my history, the reason I guess one of those things was the call out about ventilation, but really, I could call out, you know, if you have to ventilate a kid, you know, we need to use the right mode, the right tidal volume. If we don't, we need to be using, you know, a good surfactant. I would say probably not Surfactant. It's older and it's larger volume, and it's just there's probably more side effects with it. So one of the newer surfactants, I would call out things like making sure you're using CPAP and not intubating everybody at certain age groups. But the reason that I call those things out, and the things I hear are that um, people get stuck in, well, this is the way my doctors want it, or this is the way we've always done it here, or no one's ever had the power to change these things. No one's ever, you know, the doctors don't like volume targeted ventilation, or the doctors, you know, won't target tidal volumes. They don't like a flow sensor at the airway. All of those things are, like, I always say this, like, if people are allowed to use their preference rather than the evidence, then you're going to get, you're basically placing yourself in the control groups of these studies. So if you have a study that shows, for example, that any of those things I just mentioned are advantageous for the infant for either reducing death, reducing BPD, reducing side effects, getting them out of the NICU quicker, out of the hospital quicker. If you have studies that show this stuff and they're big enough and dramatic enough, which I would say a few of the things that I called out are, um, and people are resistant to that, what they're really doing is they're creating a situation where they're putting their kids in the control groups who are doing worse. Like, and people don't want to admit that, like, but that's the reason that you follow evidence-based medicine. Like, people just need to follow the evidence, um, even though it means change. Change is tough. Change is not fun for a lot of people, but the bottom line is there's a reason we change, and we change to improve the care of these kids. So, I mean, my encouragement to people always is, um, if you're not doing evidence-based practice and you know it, that's the first hurdle. The second hurdle is, how do you get your place to do it? You can email me and I can give you resources. I can give you references, and we can help out there as well too. But yeah, if you're not doing evidence-based practice, you should try to do anything you can do to get yourself evidence-based.
Great. Another question, do you have any thoughts on the use of RAM cannula as a CPAP interface? Is that something that you've used?
I
Hmm.
so I have played with in the lab RAM cannulas. I have talked with people who use them. Oh, let's see. My spin on this is we have stayed away from. We've had a couple of our neonatologists who have talked about getting RAM cannulas, and we've looked at and talked to other institutions. And I think I'd encapsulate it by saying this: I totally understand the reason why people like that use RAM cannulas. They love it for the interface. It's basically a nasal cannula without a seat. You know, you're not having to put lots of stuff on a kid's face. So it's probably more comfortable if you could survey the kid, and less breakdown potential, less maintenance for caregivers. So it's a much easier interface. What I've seen in the lab and what I've talked to people about is what you have to do when you're either thinking you're giving CPAP or thinking you're giving NIV with the RAM cannula. You are doing things that you, on the, I'll say on the ventilator or device side of that cannula, to push flow through the smaller diameter cannula, to hope that you are doing things in the kids. So you're doing things with very high pressures on the device side, having no idea what the pressures are in the kid. And that is the primary reason we've stayed away from it, is because we know, for example, I might be bumping my pips up on a RAM cannula to astronomical levels and the places get comfortable with what that is, I don't know what I'm doing on the kids side. I just see their physiologic parameters getting better. And the problem with that is following physiologic parameters is not necessarily the best thing. Like, you know, just to go back to ARDSnet, if you follow the pulse ox and the PO2s, the better pulse ox and the better PO2s in ARDSnet were the ones who died more frequently. So not knowing the pressures I'm giving the kids, not knowing the tidal volumes I'm inducing, I just don't like that about the RAM cannula. And that's really that's a skewed view. That's me talking with people who use it and how they use it, and then playing with it in the lab. So it's probably I'm not a cheerleader, you know, for RAM. So that's my I'll say definitely skewed view of the RAM cannula.
Great. Thanks so much again, John, for your excellent lecture. I'm going to finish with this one comment that was given to us in the question box. This was very informative. I thank you so much for learning about the history and how we evolved over time. The contrast and comparison was great imagery with the graphs. Thank you so very much. Couldn't have said it any better. So, Brittany, thank you for writing that in there.
Yeah, thank you.
Yeah, so again, John, thank you so much, and make sure that you guys answer the survey questions. If you have any suggestions, go ahead and send them along to me, and we look forward to seeing you all again. I hope you all have a wonderful rest of your week, and we'll talk to you again soon.